All right, I want to move into the CIMT, which we've touched on a couple times. And then you mentioned the CT angiogram. So who are these tests for? And then talk about a general overview of each.
Okay. So let me go back maybe and get a little bit broader. The original, we talked a few minutes about getting a stress test and then go into the cath lab and getting an angiogram. Let's back up and acknowledge that, gosh, 30, 40 years ago, a new test came out. It was called a calcium score. It was a type of, I think, CT, where they were able to adjust for the movement of the heart, and they were looking at calcium in the arteries of the heart. That was another one of those tests where the cardiology community really had a hard time accepting it. It didn't make a lot of income. It was a new test. You had to be willing to think outside the box to do that, but it still told you good information. Here's the problem with calcium score. We'll get, it's one of the more common reasons for coming to see us. Somebody will have heard about a calcium score, they'll go get it, and they'll have a positive one. They'll have over 1,000, 2,000, 3,000, 4,000 even. And they decide, oh my gosh, I'm dead man walking. They come in and see us. We use other things too, because we know that calcium is actually stabilization. The assumption that a 1,000 calcium score means you're going to die is also based on the assumption that you haven't cleaned up all of your plaque. So therefore, you have a whole bunch of soft plaque there. That's not always the case. In fact, these people with these really high calcium scores do tend to be people that have gotten religion, lost 30, 40, 60 pounds, and have stabilized and calcified all of this soft plaque that they had before. Now, there's been another test which, so said that to set up this item, this understanding. So really what we want to know is not so much calcium, right? We want to know soft plaque. Does that make sense?
Yep. Well, I do want to come back to the hard plaque, but yes, for now.
Okay. So is there a test that will show us soft plaque? And in fact, there's been one for a long time. It's called CIMT. Carotid, this is the carotid artery. Intima, remember that lining of the artery wall where Fetke was talking about the glycocalyx, which comes off of the intima, and I was talking about the enema. So carotid, Intima-Media, remember the media is that muscle layer. So you're looking in between those two. Remember I said the plaque is not really inside the artery wall, it's in between those two layers. And a CIMT is a harmless ultrasound technology. There's no radiation. Costs $200 to $400 compared to most of the other technologies that cost thousands now. And it tells you something that you don't get from a calcium score or a stress test or most other technologies. It tells you soft plaque. And that's what we really want to know. Now, if you're sitting there listening thinking, yeah, but this is up here, I'm worried about here. Well, two counterpoints to that. Up here also gives you risk for a stroke. And the other counterpoint, which is even more important, is this is a metabolic issue. It's not an anatomic issue. If you have it here, you're going to have it here and everywhere else in your body because glucose problems, inflammation is a metabolic problem. It's not a localized issue. So that's the CIMT, carotid Intima-Media thickness program. And you look to see how thick that space between those two layers is. There was a big study with over 10,000 people in Italy at a place called Caffè de Caves. It looked at it, and here was the question. They knew that if they had enough plaque to interrupt flow, that created risk. The question was, what about people that had plaque, but it wasn't enough to interrupt flow? And they did that. They looked at it and found out, sure enough, major increased risk if you had plaque, even that was not enough to interrupt flow. Well, since then, in more recent studies, oh my gosh, it was one of the Ivy League prevention programs. I'll probably think of it later. But they have said the same thing. Look, what 2/3 to 3/4 of heart attacks occur in people that have plaque, but it's not enough plaque to cause a problem with flow. Hence the reason why a stress test doesn't predict a heart attack. So you start looking at that, and yes, you would think it would be valuable. You'd think a ton of people would do it. But here's what happened. It was a problem of garbage in, garbage out. I won't go down the bunny hole of the technology, but a lot of people did these studies with CIMT and basically did not know what they were doing and put a lot of garbage into the literature. Academic centers, other centers that had good quality control had great evidence coming out of it. There has been back and forth, up and down. My friend Todd, who runs a program doing this, has actually testified to the standards committees on this. They get closer to accepting it and using it, and they have done that. They do accept it now. But then, out of the blue comes a whole new technology, CT angiogram with AI. Now, CT angiogram, it's a CT, you remember like the CT calcium score, but it's a whole angiogram where you inject dye. It actually shows the anatomy. I personally have been afraid of it because when you see the anatomy that good, you're likely to say, hey, wait a minute, if I just put a stent right there, I'm going to fix the problem. And it turns out that, at least among my patients, I'm not really getting that kind of reaction. What's happening is people are looking at the right thing. They're saying, hey, what should I look at? And here's what they should look at. Once you get AI analysis involved with this process, number one, the quality of the program, of the result, improves greatly. In fact, I would advise people, anybody that's getting a CT angiogram now, if you don't get it with AI analysis, then you're really doing yourself a disservice. Once you get that, what you want to look for is what you and I have already been talking about. You want to look for soft plaque and the amount of soft plaque that you have. So what's going on with my patients now is basically on an imaging perspective, if somebody's got relatively little risk, my advice is you don't really need to do a CT angiogram. You know, it's a couple of $1,000. On the other hand, if you're so inclined, it doesn't hurt people. And when you get one, if you have major risk, most of us would agree, yeah, you probably ought to repeat that annually. What we do in our clinic is most people in our clinic don't have major risk, and most end up doing one of these every 3 to 5 years. That's what the cadence is going to be. And on off years, they're going to get a CIMT.
When you were talking about CIMT there, you mentioned the fact that carotid artery is good to look at because it gives us an idea of the whole arterial system, which for me brings up the veins.
Yeah.
And given everything we've talked about today, why are they not affected by all this?
You know, there's a couple of things to think about with the vascular tree. We had a patient, a viewer on our live, today's Friday, just yesterday, asked the same question. He said, why not veins or why not pulmonary arteries? Well, think about it. Veins and pulmonary arteries have very, very low pressure. even the pulmonary artery is going to have like 20. Veins are going to have even less. And, you and I are probably, your blood pressure is probably a little bit lower than, well, actually mine's corrected to 120/80. So those are the kind of levels. When my heart's pushing and the arteries are pushing down, it's up to 120 millimeters of mercury. When it's relaxed, it's still up at 80 millimeters of mercury. In the arteries of the lungs, 20, 25, and in the veins, 2, just enough to get back up to the bloodstream. So when you think about plaque and how it forms, you remember we talked in the beginning that you get some injury to that lining and cholesterol starts to transcytose, or to go through that damaged glycocalyx, through that lining cell, but it can't go through that muscle layer, the media, so it gets stuck there. You remember that?
Yep.
So that's really only going to happen mostly. You're only going to get significant plaque formation mostly in these arteries that have significant media or muscle covering, in which it's, 120/80 kind of pressure.
All right, makes sense. Before we move away from testing, we went deep into conventional versus the way you do it. Even within the way you do it and talking about a lot of the great tests that are out there today, we did get into a lot of detail, and I want to make sure people who are leaving this feel like they understand the basics. So we'll say somebody who is middle-aged, they feel metabolically healthy, but they want to look at their vasculature and determine whether or not there are problems there and plaque buildup. What are the basic tests they can have done?
So it depends on whether you go to, you do lab tests or not. Let me just say this one thing, and I'm not sure whether you meant to use the term or not, but it gives me an opportunity to bring it out. Nobody has ever felt plaque forming in their arteries.
No, I didn't mean it that way, and I know that.
I know you know
I
that.
just mean somebody that feels metabolically healthy. Somebody kind of like me. I feel metabolically healthy. I'm middle-aged.
Yeah.
What do I need to do as somebody that wants to be preventative? And again, given the fact that we don't feel it, without going overboard and overwhelming people, what are the great tests that we can do and still keep it simple to figure out whether or not we have any issues cardiovascular wise?
So I'll go back to the box that we talked about a few minutes ago, and that's focused on somebody that says, you know what, I don't want to go to a lab. I don't want to spend $500. I want a good practical answer. And you'll get that for less than $200 right there at home. Now, let's say you want to go to a lab. Then I'd add a couple of things to it. The insulin response. Remember, you can't get insulin at home. I'd also get the fractionation in terms of labs. So those together are going to add maybe a couple of $100 more. And let's say you got a couple of $100 more and you really want to know, I would get a good CIMT at that point. So you said you're what, in your 40s?
Early 40s, 42. Yeah.
So I think that really, hopefully that helps you in terms of, how about your audience? What age groups are your audience?
When I look at the YouTube stats, the biggest group is actually 65 plus.
Yeah, mine too.
So older group.
Yeah, mine too. So again, for 65 plus, you've clearly got the risk. We talk about 90% of the adult population having at least one sign of poor metabolic health. That speaks to another component of, do you really feel like you're metabolically healthy? It reminds me of that. You've seen the Dirty Harry movies. or any of them?
I haven't. I know of them. I should see them.
The most famous quote out of it is, I've got six chambers in this gun. I've fired 4. Are you feeling lucky?
I've heard that one. Yeah.
And this is, again, you got to ask yourself, if 90% of us have some problem with this, are you really feeling that lucky? Do you not want to test? So I'm glad you brought the question up.
Okay, so your kit, fractionated on top of that, fasting insulin on top of that, that goes along with not fasting insulin on top of the OGTT.
Correct.
And then the CIMT.
Yes.
That would be the complete baseline kit, we'll call it.
Very detailed pickup, especially on that difference on insulin, because we will pick up another 15% of people with problems who have a perfectly normal OGTT. And these are people who their pancreas is working harder and they're putting out too much insulin to get the response that they need. So yes, you're exactly right. Start with a kit. If you've got a couple of $100 more, go ahead and add insulin response to that OGTT and fractionation. And then if you got a couple of $100 more than that, usually $300 to $400 more, get a good CIMT. And you may want to call our office before you get a CIMT, because there's a couple of things about imaging groups. A lot of people will come to us and they'll say, I've got my CIMT. They called X-Rays R Us across town. They said, yeah, we do those. We do ultrasound. We do ultrasounds of the neck all the time. And what they actually got was an ultrasound of the neck. CIMT actually involves some more technical IT evaluation of the specific imaging. And don't waste your money. Make sure that you get the right kind. You don't want garbage. You want a good test. Those are some of the things to think about. And I appreciate your focus on the details and your ability to pick up nuance.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
I started as an ER doc. I love doing emergency work, but most of these things coming into the ER should have never happened. High levels of glucose or even high levels of insulin irritate that